So let us start today's session. Uh, I guess I am quite audible, and today we will discuss about myocardial infarction. So before starting, I would like to ask, what is difference between ischemia and infarction? Ischemia and infarction. Can anybody tell? Yes, please. Yes. What is difference between ischemia and infarction? So, friend, yes, ischemia is due to lack of oxygenated blood supply to certain area, and uh, please don't message. It create disturbance. Whenever I ask you, then you can ask. Okay. Uh, Let me. Yes. So ischemia, Dr. Sunil, right? Ischemia is reversible, and it is due to the lack of oxygenated blood to a certain part of the body, and there is a pain, and it is irreversible. So similarly here also myocardial in the heart, we will call ischemia as irreversible, and if reperfusion is there, so it will be reversible. But infarction is the permanent death of the cell. Okay, so that we call a myocardial infarction. So we often use the term myocardial ischemia and myocardial infarction. Indeed, so we should be very clear about this. So let us talk about little bit about the pathology of this myocardial infarction. So let us proceed now. So here we go. So now, as you can see, this is a coronary artery disease patient, and this is atherosclerotic plaque, and you can see certain amount of occlusion is there. So you might have seen the patient having a 80%, 90% blockage or blockage some kind. So these are the atherosclerotic plaque, and usually we call it a coronary artery disease, and a lot of patients are on the medical treatment, and doctor often advise them to go for a angiography or plasty, but it depends upon the patient, and sometimes patient hesitate, and sometimes other due to other causes. So what happens when this progress, this atherosclerotic plaque, this is a fat, and as it progress, it may rupture into the lumen. So as it will rupture, so what will happen? You can see here, so it's got rupture, and now there will be thrombus formation. Okay, so this is how we go. Let me draw. Uh, Let me draw it a little bit. So suppose this is the coronary artery. Now there is a certain amount of blockage due to plaque, and when it will now right now what happens? Patient is having this on medical treatment. So whenever there will be exertion, there will be pain on our exertion. You might have heard that this coronary artery disease patient, whenever they have exertion, they have pain and shortness of breath. And on resting and on resting and nitrate, so this vasoconstriction, vasospasm get relieved, and immediately patient get relieved. But now we are not talking about the we are talking about the coronary this myocardial infarction. So this will rupture. Now what will happen? So it may occlude the further distal part of the coronary artery. So what will happen? So there will be a complete occlusion. So the complete occlusion. So whatever the part of the heart uh, supplied by that particular artery will get start ischemia, and as the disease progress and there is no reperfusion, so it will lead to the necrosis. So time is a muscle. Okay, in case of myocardial infarction, more time you will waste and more will be damage to the myocardial cell or that particular part of the heart. So here you should be very conscious about it. And let us proceed and see what are the other changes, ECG changes, and what are the criteria. So, friend, most of the doctor I have seen that they don't go with any kind of criteria, just on the basis of some ECG, some ST elevation or something like. So they start calling it as a MI. So let us understand the WHO World Standard American Heart Association criteria. So these are the two criteria. So this was given 1979, and there is a revised criteria in 2000. So now let us first discuss about this criteria. So it's a cardiac troponin or so here, and as we can see here, so this criteria revised in the 2000. So they say that cardiac troponin should be raised and on the basis of coronary angiography. But in country like India, this is not applicable because in rural area even ECG machine is not available and there is lack of medical facility. So and that most of the patient present late and some of them not able to reach the higher center where the advanced technology like CAG are present. So we have to follow the basic criteria, but that was given in the 1979. So we could not base on the recent criteria like troponin or this angiography or like that. So we will follow strictly this criteria. So number one is ongoing chest pain. So what do you mean by ongoing chest pain? So please be strict. These are the three criteria, and one should fulfill two out of three given criteria to stamp a case as a MI. तो तीन में से दो criteria आपको fulfill करने हैं to make the diagnosis. Here I have noticed that lot of doctors do this mistake. They share ECG, ask for the direct diagnosis. We need at least two criteria. Okay. So number one is ongoing chest pain. So when I say ongoing chest pain, what does it mean? So number one, typical ischemic chest pain. Okay, you know that pain or ischemia radiant have various parts, and typical chest pain will be there, lasting for more than 20 minutes. So why this 20 minutes is important? Let us understand and go back to the pathophysiology first. So first, what happened, patient? Let us understand in full depth and dimension. So now, friends, what happened? Just imagine a scenario that there is a patient of coronary artery disease already medically diagnosed or not, may not be medically diagnosed. So what happened when this patient is having a pain on exertion, there is a vasospasm. Okay, so there is a vasospasm, but usually what happens on rest or giving taking nitrate as advised by the doctor. So this vasospasm is transient. So chest pain will be there, but it will be not be more than 10 minutes or like that. But what happens? These patients usually know that they have these kind of pain, and so they usually ignore and just follow the previous treatment. A lot of ignorant people are there. So what they do, they think that maybe this pain could be same angina pain like a previous, and it will be uh, uh, everything will be fine and we should not be much aware. So doctor always tell if chest pain आपको ज़्यादा time के लिए रहता है तो don't mistake it with the previous. So you have to visit the doctor. So now in this case, in myocardial infarction, this got ruptured. Now there is no chance that on relief, just taking rest or nitrate, it will resolve. So now it is occluding the complete artery. So it will not help. Now, even nitrates are not going to help, and there is a occlusion. So that's why this 20-minute window period, time period, is given by the AHA, just to make sure that the pain of the myocardial infarction should be at least 20 minutes ongoing pain. And it's a severe pain, as you all of you know. So we call it as ongoing chest pain. So not relieved by rest, not relieved by nitrates. So this was typical chest pain. So always when you share the case and share, demonstrate, and discuss, always use this term ongoing. It's not like intermittent or like that. Okay, so you should not miss. You should be very specific. Number two, serial change in ECG tracing. Again, friend, lot of doctors think that just one ECG finding is enough. So let me tell you, there are serial changes in the ECG from time to time that I am going to demonstrate next. So number three is cardiac biomarker. As you know, sometime elderly diabetic patient may present with a silent, in layman language, silent chest pain, silent heart attack. So in layman language, we call it. So what happened? Pain is not there. So other symptoms are there, like uneasiness, perspiration will be there, the ghabrat will be there, and patient will feel uneasiness but no chest pain. So in that case, you can take serial tracing, and also you can confirm with the cardiac specific biomarker like propionate, most commonly used. And uh, so one must fulfill two out of three criteria. It's not like that somebody is posting some ECG and it's having some teen version or like that. And without taking proper history, you are making diagnosis. No, you must ask another patient what is the complete presentation. Just on the basis of ECG, it's not good. And I will show you the cases. There is ST elevation, but there is no MI. So you should take care of this criteria always. Now next. So friends, look at this figure. Here we are going to discuss about the serial changes. Okay, so these are the ECG changes we are seen in the MI. So now what happened? Immediately within minutes, you can see a peak tall P wave or peak P wave. So can anybody tell me what is the criteria to call a T wave as a tall? Please type down. What is the criteria to call a T wave as a tall? Yes, please. There must be some criteria, na? You cannot call it that ये लग रही है tall तो tall है. No, it's not acceptable. You should have a proper criteria. So what is the criteria to call a T wave as a tall? Yes, nobody. Why, friend? Yes, Dr. Priyanka, very good. Boxes, yes. Limb lead, it should be. Dr. Vinas, not A8. It should be. Let me write down. So tall T wave. It should be more than 10 millimeter in chest lead. Chest lead, you know, V1 to V6. Okay, and or it should be more than 5 in the limb lead. Okay, so this is the criteria. You must count. Okay, all of you know how to count, how to measure the height of the tall T wave. Already is a very basic. And if the T wave is more than 10 millimeter in lead, V1 to V6 chest lead, or in limb lead, it should be more than 5. So only then we'll call it tall T. So, friend, this is the immediately after the onset of the symptom. Immediately you will see peak wave, which is usually missed in the clinical scenario because of the late presentation. Within minutes to hours, it appears and gradually disappear. Now, most important part of the myocardial infarction is the ST elevation. Now, again, friends, I am telling you Please don't remain always dependent on one ECG. This is the most common mistake. Always take serial tracing. So as we proceed, I will be telling you why serial tracings are more important. So you can see if you suppose have taken the ECG immediately after arrival of the patient. So this is the ST elevation is like this. So you may not be very sure that it is the ST elevation. So please repeat the ECG within 10 minutes, and within 10 to 5 minutes you will see change. If you compare previous, this will be progressive changes. So you can see here. So you must always take serial tracing. So that is very important. Only then you can make that. These are the serial changes of progressive ST elevation. Otherwise not. So now let me raise this. So now again, progressive ST elevation minutes to hour. Okay, maybe more, persist maybe more. Although these are the some of criteria or like this, not some kind of criteria, but clinical practice. You know that maybe it can persist 24 hour up to the 1 day तक भी persist करते हैं. So what happen next? There will be loss of R wave. So this R wave will get lost. So what happen? Now see, ये R wave नहीं रही. So ये will be like this. So there will be tombstone appearance like this. So if there is R wave loss, and as the progress, this is progress, there will be T inversion. Now T inversion, now you can see here, there one is ischemia, and this is a non-perfused patient. So now as the disease progress, you can see this is the infarcted zone. So what will happen? Ischemic zone, and ischemic zone will is ischemic zone, and it will leave behind a scar like this. This is a dead ischemic zone, infarcted area. Okay, so it will heal or like this, and rest will heal. So you will see a Q wave which can persist from um, uh, days, weeks, but just by looking at the Q wave, not in every ECG coming, now you don't confuse it with the Q wave is there until unless you have a significant history. The patient is coming with medical record and you have all history, only then comment on Q wave. Just on the basis of Q wave, don't shout about MI. I've seen a lot of patients, I don't know why they have just stick to this criteria. So you should look for the progressive SPP and clinical presentation if the pain was there or not, and their medical record would be there. Previously, patient were maybe admitted to some center, lower center, or local clinic. Then he may be referred to the higher center or your clinic. So you must collect all the history. That is most important part. Now, friend, this is the chest pain. You may say various area. The most important thing I would like to demonstrate here will cover the epigastrial region. Why? Let me tell you. So, friends, this epigastrial pain or discomfort is also chronic smoker patient or chronic smoker. So, let me tell you, it's a very common mistake that it's very common mistake that I think I'm audible. Yes. So common mistake. Let us discuss about the epigastrial area. Why I'm talking about this? Patient chronic smoker. Chronic smoker may usually have epigastrial discomfort and maybe have gastritis, suffering from gastritis. So usually these kind of chronic smoker feel epigastrial discomfort or pain. They visit to the doctor and doctor know that he is a chronic smoker and without taking ECG, he doctor may discharge or on the OPD visit give some treatment in the form of proton pump inhibitor or like that, antacid and discharge without taking ECG. But now the pain of inferior wall MI, where the RCA involved, inferior wall MI may mimic is can be presented as a epigastric discomfort or pain. So there are high chances that the doctor can miss if you chronic smoker come to you, and he may also have history of certain kind of epigastrial discomfort. Now he is not able to appreciate, but you should always take care of this. Chronic smoker are most prone to the MI, and due to the similar presentation, you should not miss this case, or you should not get confused. You must take the tracing. You must agree the patient to the telemetry unit and take the serial tracing. If the ECG is normal, then you can discharge. Otherwise, it is higher chances that these kind of patients in India you usually ignored, and later when they are discharged, they present with a severe arrhythmia, dysrhythmia, and maybe fatal, they can be crashed. So you must take this precaution. Always, if he is a chronic smoker, always take ECG only then discharge. Don't ignore this kind of case. And because I'm saying this because I have seen that every day, a lot of in out of hospital, these kind of cases are ignored. So now I was just asking about the tall T wave. So here is my diagram also. So friend, although this is the thing that bookish knowledge, narrow, base point in blah blah blah, but these are not applicable, very well applicable. So as we know that tall T wave are seen in the hyperkalemia and hyperacute ischemia. So, friend, in hyperglycemia, duration will be very low. Okay, initially there could be these kind of, but shortly it can change into the ST elevation. So here is history play important part. So in hyperkalemia, patient may be having some chronic renal disease, है chronic kidney disease, CKD, or like that. So these symmetric narrow base pointing, painting, these things will remain bookish or like a definition. You're not going to able to apply in the clinical scenario exactly. So you can make number two important part. These changes will be hyperkalemic changes will be seen in the almost all the leads, but these are specified to the zone of ischemia, that particular lead. Suppose inferior wall MI is there, so these voltages will be in the lead 2, 3 AVF or like that. And lateral wall MI is 1 AVL, AV56, they will be there. But these are present all over. Moreover, you can symptomatic, you can check the patient clinically, whether it is a patient of hyperacute ischemia. Presentation are very different. So we cannot too much rely on this symmetry or like this. You must clinical presentation is much more important than this bookish knowledge. Let us proceed now. Now here is a chart I'm sharing. If you're a beginner, it's a very good chart for you. So as you can see the various area, this greenish or this this is the lateral wall MI, and the lateral wall is these leads, lead 1, lead 2, AVL, V5, V6, this uh, is the lateral leads, and is yellow area 2, 3 AVF represent the inferior territory. So like that, anterior, inferior. So for the beginner, it is very good to remember. Otherwise, now friend, here I would like to add one thing. That is, in some cases, you may see that there are ST elevation in lead 1 and AVL, but not in here. So, can anybody tell me how could it be possible? ST elevation seen in the 1 and AVL, but not in the V5, V6. Can anybody tell me? Yes, please. In which condition? Yes, please try. And don't watch it like YouTube video. It is a live webinar, so you must participate. Because you participate, you will learn. It's your benefit. Otherwise, you may watch some YouTube tutorial or like that. So you must participate. So, friend, if you don't know, I would like to tell you. What happened? LED. Now, drawing here, I think I should draw somewhere. Here it's not visible. So, suppose uh, this is the LED and this is the left circumferential. So, friend, this LED gives branches as a first diagonal, second diagonal branches. We call it as a D1, D2, D1 like diagonal. So, friend, diagonal branch, uh, if there is only a occlusion of the diagonal branch. This is the diagonal branch suppose. So, let me draw it again. It's not very good. So, let me draw again. So, friend, this is suppose the left main coronary artery and it divides into left circumflex and left anterior descending artery, which is a very common, this LAD, and also known as widowmaker artery. Okay, this is the least common. So this is the left circumflex ileus. Let us draw it. This is the LAD. So this is the diagonal branch. So if the only diagonal branch is occluded, then what will happen? You will see ST elevation in lead 1 and AVL and sparing lead 5 and V6. So this is we called it as a high lateral MI. High lateral MI. Okay. We will call it a high lateral MI. High lateral MI. Okay. So if only ST elevation seen in the 1 and the AVL and sparing other lateral waves. So now on the basis of this, you can also make some kind of conclusion that the suppose if the occlusion is below the distal occlusion, we will say na distal occlusion. So after giving branch first diagonal, so it will get spared. So in that case, you will see AVL and AVF have not this one and AVL is paired. So no ST elevation, but V5, V6 was showing ST elevation. So this is how you can make distal and the proximal occlusion of LAT. So important. So you must. So now next is the reciprocal changes. So what happens when usually if you are beginner that don't pay much attention, first try to identify the ST elevation. Okay. So what is ST this reciprocal changes? If you just flip this, okay, flip this vertically. You have to flip this vertically. Vertically mirror image. If you put an mirror here, so you will see just opposite this kind of morphology. So this is stimulation, this is depression. So what happened, patient friends? Most of the doctors are beginners. They start learning. Okay, so they start paying more attention toward the SP depression. And there are other kind of STEMI like N STEMI, where there is SP depression or T inversion. So they think that this is the N STEMI and they get confused. So I always tell my student to just follow the uh, try to follow the main criteria that is ST elevation. And when you get expert in identify ST elevation, and then you can look for the reciprocal changes also. So as I will be discussing with the help of some ECG later. So, now here is one chart I'm sharing. So friends, anterior. So what happened? Anterior leads are V3, V4, and you will see reciprocal changes in the 2, 3 AVF, and accordingly the vessel. Okay, and inferior 2 3 AVF, everybody know, and you will see reciprocal change into 1 AVF, V2 V4, okay, RCA included. Lateral, you know this, 1 AVL V6 to V5, and inferior lead will be the reciprocal change issue. Now this is posterior wall MI. I will tell you what are the posterior leads, because only after telling you what are the posterior wall MI lead, how to place them, only then this will be helpful. So right now just imagine up to lateral part. So friend, what are the what treatment will you give in a MI patient? What basic or primary treatment you will give, and what are the benefits? Can anybody tell me what you give? Here is something clinical important I'm going to discuss with you. Yes, doctor, if I have right, Mona. Let us, Mona, what is Mona? So Mona, uh, so this is the morphine. Nowadays it's not that much available, but it has a very good painkiller effect. But also, friend, importance is, and patient of MI is scared of death. So what happens? It will be sympathetic nervous system will activate, and uh, there will be tachycardia and visual fast. So it will lead to the more worsening of the condition. ठीक है? So worsening condition हो जाएगी. Yes. So that's why morphine is very effective. It's a good painkiller, and patient will have some. Although this is narcotic nowadays not available, but patient will be not having the anxiety, stress, or fear of that. So he will get sedate, and he will the it will help in the recovery, because if the sympathetic nervous system is activated, then heart rate will be more, vasospasm will be more. So number two, oxygen. Oxygen is also very important, because we know that the area, ischemic area, receive the very less oxygenated blood. So if you give oxygen, so whatever blood supply is there, so it will help in the delay of the this ischemic to infarction. So oxygen is also very important. Now nitrate should be given with the precaution. Yes, Dr. Sandeep, everything I will be discussed. And statins, yes, yes, everything I will be discussed. Just Dr. Rekha has mentioned Mona, so I started this. Okay, old is gold, and nitrate. So nitrate should be given with precaution, because what happens? Although nitrate can be helpful, especially mostly in the those patients having a so uh, but one of the side effect of nitrate is, suppose the patient having a severe regional motion defect, or a cardiac output is low. If you give this nitrate, it will cause uh, this relaxation of the vasodilation, and the condition may work. So nitrate should be given with the precaution. Yes, atorvastatin, hypolipidemic drug could be given, and other could be given. Let me give you very important. Yes, hypotension. It calls hypotension nitrate. Yes, Dr. Sandeep. So it should be used with the precaution. And last is aspirin. So aspirin is very important, but in olden days, there was a saying, famous saying I have heard. If you give 300 mg, 300 mg, suppose 300 mg by oral route, so patient will get at least that much time that he can go to the higher center. इतना टाइम मिल जाएगा कि पेशेंट हायर सेंटर तक पहुंच जाएगा. 300 mg एक बार ओरल दे दी है एस्प्रिन. ओके, एस्प्रिन. So immediately you can also educate your patient. Suppose if he having chest pain और कुछ नहीं है तो just aspirin. Okay, you can also give clopidogrel. That is also important. Atorvastatin. All these are important. Okay, but I am telling you oldest growth, that is aspirin. Very important role. Okay, so now No, this is the chart. It can give you idea. So it can give you idea about the culprit artery. So you can see here inferior wall. We know that RCA. So this so you can see here RCA. So 85 to 90% case it is supplied by RCA only, and that is a right dominance. The left dominance we will talk about. ALCX is rarely, and this is RCA mostly. LED you can see here LED, and now well I will teaching the posterior MI, then I will be telling you right and left dominance, and this confusion will get this. I will be clearing this confusion. Now what next? Any doubt, any problem, you can ask. So now, with the help of ECG, I have tried to demonstrate here that you can see this is the inferior wall MI. So you should be able to appreciate these ST elevations in 2, 3 ABF. So this is the inferior wall MI, and as a result of which, you can see reciprocal changes in the lead, this lead 1 and ABL. So sometimes they are so close that they form dead man sign like this. I will be sharing slide of that. So this is the reciprocal just to demonstrate, and let us proceed. So this is an semi non ST elevated MI. Now problem with this is that lot of patients just go through an STMI, and they what they do every ST depression they start stamping at a MI. Okay, so it should not be confused. So I have seen lot of confusion is there. So in anatomy there will be horizontal. So there will be partial reperfusion in this case. So, but students usually confuse the reciprocal changes of the MI as a and MI. So that should not be taken. You should be very careful while making your interpretation. So don't go much too much by this by looking depression inversions, and as you know T inversion I have told you in MI you can also see T inversion. So this is enhanced MI. You may see ST depression, but it is partially perfused. And now, friends, let us discuss the posterior wall MI. Now, first you can see here the inverted image. If you know the let me let me draw. So this is suppose RCA, right coronary artery. It gives a branch to the PDA, posterior descending artery. Now, in 90 to 90 to 80 to 90 ले लेते हैं. 80 to 90% cases, this this posterior descending artery arises from RCA. So we call it a right dominance in 90% cases, and this PDA, posterior descending artery, supply to the posterior wall MI. So usually posterior wall is not posterior wall MI. Okay, usually a posterior wall is not seen in the this conventional ECG. So we have to take the posterior tracing. So I will be demonstrating about that. So why I have given this? This maybe this supply the posterior wall and most of the part of the conduction system. But in 10 to you can say 15 to 10% cases, it arises from the LC or from the left side. circumflex ciliates. Okay, sorry, left circumflex. So in just 5 to 10%, this PD arise from the left circumflex. So we call it as a left dominance. This is left dominance. Left dominance. This is right dominance when PD arise from the right coronary artery. Now, so what happens when this supply to the posterior wall? So whenever there is an RC occlusion, it will almost always associated with the पोस्टीरियर वॉल एम आई तो जब भी आरसी आपका इंफीरियर वॉल एम आई होगा आरसी ओक्लूजन होगा इट विल बी ऑलवेज एसोसिएटेड विद द posterior wall mi and you will see reciprocal changes in the v1 v2 like this v1 v2 like this as a posterior wall mi st elevation reciprocating to the st elevation of posterior wall mi which is not seen in the conventional method. We have to place the lead. So always check v1 v2 for the st depression in case of RC involvement or inferior wall mi. You will always find 90 to 80 to 90% you can say. So because it is almost always associated. Now, uh, now here is a small point, a small thing, but it could be useful in case you are suspecting left dominance. So what you can do, this is the posterior wall. Uh, how to place the it's on the posterior wall. So what you have to do, you have to remove lead uh, V4, V5, V6 from anterior chest wall and place on the posterior chest wall. Just in the tip of the scapula in fifth intercostal space. Okay, intercostal space will remain same. You can place this and left paraspinal region, just left paraspinal region, fifth intercostal space. This will be placed. You will V9, V8, and V7 will be placed just between V8 and V6. That is a point on the anterior chest wall. तो anterior के उस chest wall के point से जहाँ पे V6 प्लेस की and V8 के just middle में हम V7 को प्लेस करते हैं and we'll take tracing and what we'll get, let us see. So here is one more diagram I want to show. So what we have done, friend, if we have to take posterior tracing, so what we have done, we have kept these leads as such, V1, V2, V3 as such. इसको ऐसे ही रहने देना है and just remove V5, V6, V7 and place them like this and take the tracing. Sorry, if I'm not here. So this is the anterior. What you have to do? You have to keep 1, 2, 3 as such and you have to remove 4, 5, 6 posteriorly like this and you have to take the tracing. Not much difficult. Just to, in case you are suspecting left dominance. So after placing the chest lead to the posterior wall, what will you see? You can see here what we have to do. So machine will not write down V8, V7, V8, V9. You have to do this marking correction. So V4, just you will erase V4 and write down V7. V5 की जगह V8 आ गया, V7 की जगह V9 आ गया. So now you can see here by placing lead at the posterior wall, we can see the this ST elevation. Okay, so this become clear now. Uh, Although it's not very useful, even if you see this is the inferior wall in my pen. So in lead 2, lead 3, and here is using EBVF, there are ST elevation, as you can see clear cut. So this is RC occlusion, and you will see this reciprocal changes in this V1. Here it's called V1, V2. Thus reciprocal changes V3. These are due to reciprocal changes of the posterior wall. This. So here we have placed lead and we have seen the ST elevation. And without placing lead, if you can make out just by looking at the depression in the V1, V2, V3, that posterior wall is also involved. So as I have told you that inferior wall is almost always associated with the posterior wall. So for confirmation, you can take the posterior leads like this and demonstration purpose. And this was just for the demonstration purpose. Otherwise, clinically, it's not of much significance. Wasting time in MI patient and placing lead from here and here to there. So now, friends, there are uh, one condition, important condition, that is a pre-infarction state, or we call it as a Wellen syndrome. So what happened in Wellen syndrome? Now, friends, this is a pre-infarction state and usually missed if you're not able to appreciate. So what happened? There will be, suppose this is a coronary artery, and there is a occlusion, thrombus formation. Sometimes what happens, friend, uh, there is a spontaneous lysis of the clot. अपने आप ही वो रिजॉल्व क्लॉट लाइसिस हो जाती है एंड पेशेंट विल हैव हिज चेस्ट पेन. ओके, उसको चेस्ट पेन होगा, एसटी एलिवेशन होगा, but as soon as the patient arrives at the clinic, this ST elevation will resolve. So what will happen? Maybe patient having a chest pain last night, he can be present to you, saying that it was like heart attack and like that. What will happen? This was occlusion actually. So why just underwent spontaneous lysis on its own. So spontaneous lysis, and this is not a good news. Spontaneous lysis हो गया because you will see lot of, this will break down into lot of clots like this. Now this may cause, this is a pre-infarction state. So what will happen? There is ischemic, there will be ischemia, pain, there will be a stimulation. So usually patient will having, oh, this is not recorded. But I have cases where I can show you that patient come with a typical chest pain, ST elevation was there, and there is spontaneous lysis of the clot. The clot get dissolved. What will happen? It will leave behind two kind of morphology of T wave. Number one, biphasic T wave, and number two is giant inverted symmetrical T wave. So we call it a wellness type A and type B. So this one is more common, 80%. This is 20 to 25%. So upstroke, initial upstroke followed by downstroke. So friend, whenever the patient come to you, maybe he not giving the history proper. And if you see this kind of wave, so this is the pre-infarction state. So it is as much as dangerous as the MI, because this may land up in the MI any time. Because I have shown you the clot get lysis and it may later occlude the. So immediately this patient should be sent to the cath lab. No need to do any stress test or like that. Otherwise, patient will crash on the treatment. Now, one more thing, friend, just appear in my mind. So as I told you that the clot, this atherosclerotic plaque. So suppose there are two type of atherosclerotic plaque. Uh, just have a look at this. One is soft and one is hard. So calcified. So in chronic condition, it is calcified. So suppose I would like to ask a young patient, 50% narrowing को occlusion, artery 50% occlusion है, young patient है, and another is a elderly patient having just 70 to 80% occlusion. So which will be more dangerous? Can anybody tell me which one is more dangerous? So friends, in elderly, this will be chronic plaque. Chronic plaque and it will be calcified. So there are less chances of rupture. But in soft, this young patient, soft plaque, what happened? These usually seen after the COVID due to the lifestyle and recent day. You might have seen a lot of patients, young patients are dying of sudden cardiac death. So this is like a time bomb. So what happens if there is a soft plaque? So it is not calcified and immediately it can rupture and occlude. And there could be no previous symptom. Even these kind of patients having soft plaque may pass the stress test also. But when there is occlusion, there is spontaneous without any previous history symptom. Immediately, this will occlude this young patient wala. It will occlude the artery and there could be sudden cardiac death. After COVID, we have seen the increased cases of these kind of patients, sudden cardiac death at the young age due to the increased incidence of formation of the soft plaque. And this is due to lifestyle modification and no exercise, sedentary habit, just junk food, too much fatty diet like that. So what happens, these kind of young patients which are not uh, internet addiction, mobile addiction, so very less this physical work and mostly people यहाँ से वहां जाना है तो गाड़ी में या बाइक पे जा रहे हैं या फिर बहुत कम सिटिंग जॉब है मोस्टली यंग है तो sedentary. So these incidents are increasing of sudden cardiac death because this is like a time bomb. It can take and it can blow you any time. So in elderly it is calcified and in this elderly patient is 70 to 80% and still on the medical treatment. But this one is a like time bomb. So always remember this. So, so here we have completed the valence type A and type B. So let me share the ECG finding of this one. Friend, this is type A. You can see here as I already demonstrated. So there was occlusion, initial elevation and leaving behind spontaneous lysis, leaving behind this biphasic STT T waves. Initial upstroke followed by downstroke. So these are seen in the V2, V1. V2, V3 most appreciated in the V2, V3, V3 sorry V2, V3 में ये सबसे ज़्यादा appreciated होंगे. You can see V2, V3 and other type of which is seen as 70% case. These are the this pattern. Two type of pattern na, type A, type B में. So different valence wave, we called it as valence wave also. And you will see in 70 to 80% there will be deep symmetrical T inversion. Deep symmetrical T inversion. This is can be seen in the V2, V3 and also in the V4, V5. So in almost all the chest waves. But type A is only seen in the V2, V3. So giant inversion, symmetrical, and you can see here a case on CAG you can see LED occlusion and ECG showing giant inverted T wave. So friends, one more thing, it could be giant inverted T wave can be seen in the cardiomyopathy, but cardiomyopathy other symptom could be there. So here patient will have typical history. In cardiomyopathy you will see in the other lead, but this will remain confined to the chest lead. So 90%, this is a 90% occlusion of LAD. widowmaker are. So uh, this was all about MI. Friend, you can ask your doubt.